Hello, we're the PSC, a consultancy dedicated to delivering lasting public impact since 2006. 2 decades on since our founding, we're asking some of the greatest minds and our most respected friends what they see as challenges for public services in the next 20 months and what they think of the big opportunities in the next 20 years. Today, we're going to talk about some of those problems and challenges and opportunities, specifically about supporting those individuals who are high intensity users of health services. Those are the people who show up to the emergency department dozens, or in some cases hundreds of times a year. I'm Chris Bradley, a senior partner at the PSC, and I lead on our transformation work and love solving problems associated with hospitals, ambulances, and those people with urgent care needs. Some of these problems are associated with flow through the hospitals, but others are associated with demand. In partnership with the British Red Cross, we undertook a piece of research 5 years ago into the drivers behind those people that use emergency departments way more than other people. It was called Nowhere Else to Turn. Since then, a lot has changed for the better. So I'm really pleased to have a guest with me who can tell us more. Diane, can you tell us a bit about yourself?
Good afternoon, Chris. Lovely to be here. My name's Diane Hargreaves and I'm the National Practice Development Manager for Health and Care Services across all of our sectors at the British Red Cross.
Very nice, thank you. Let's to get into this a little bit, should we just start with the questions to like, what were you doing 20 months ago or 20 years ago? You
okay. Well, I'll pick both because they're a bit of a contrast between what I was doing.
Yeah.
So 20 years ago, I was working for St Helens Council in the behaviour improvement team, and that was supporting children and families and schools to get the best outcomes for young people who were struggling to manage in mainstream school for one reason or another. But I was also supporting the foster and adoption team in social care. That was to embed a new service that supported both the child and the foster carer to transition into the new homes. So it gave them a lot of support. So there was two kind of aspects to care, but it was also still within the want to support and help people as well. And 20 months ago, I was the programme delivery manager for practice within the high intensity user services team at the British Red Cross, supporting our 16 teams and ensuring that we were delivering consistent, safe practice to all the people that we supported and enabling our staff members to feel that they had the right tools to carry out their roles as well. So a bit of a contrast in roles.
Bit of a contrast, but a theme as well, I hear. Yes. Have you always been in either social services or helping other people in that kind of sector?
It kind of started within the NHS, and that was as a research assistant. And so that was kind of looking at mortality rates and sepsis. And so when I was going up on ITU to collect samples for that research, I felt more of a connection with the people, the families, and wanted to do a little bit more. So then I went on to do like counselling and psychology and looked at it a little bit more in depth, and that took me on the journey to work more closely with people on a frontline basis. Amazing.
And now you work with the British Red Cross, and you mentioned their high intensity user service. I mean, I've heard a lot over the years from doctors, nurses, therapists, others, that, trying to improve health services by just doing more of the same isn't really going to cut it in the 21st century, right? So tell me a little bit more about the challenges that you've seen, and specifically around the high intensity users that you think has now changed over the last 20 years and has changed for the future.
Well, I think what we're looking at is that growing demand on urgent and emergency care. There's no getting away from that. But I think from our Nowhere Else to Turn report that we did, it's showing that exactly the same. People are going for reasons that they feel that they're a bit more disconnected from their local GP, long-term doctor that they've had, especially the older generation. And feeling that there's such long waiting lists for things that they feel that this is the place where they get that support, that nurturing support that they need, and feel listened to and heard when they're there as well. I think what they mix it up with is the fact that the NHS is not the best place for that. that moment in time. And so they're not able to complete those onward referrals and to make sure that those signposts are in place. And so there is that rise in complexity of individuals' needs. So there's often a mix of that: health, social, psychological, housing, finance. And people go to A&E because there's an escalation in those worries, anxieties. It may be that they can't manage their long-term health conditions. And so it's looking at who's the best place to support that. So we are looking at that shift more from that personalised, community-based support, and having like a greater recognition of the role of the voluntary and community sector within prevention and crisis response as well. So HIU services reflect exactly the kind of partnership that is needed to bridge that gap. And so over the next 20 years, I feel that we need to become more data informed, become more relationship based, and that will benefit systems wide.
Understand. So you see that the people's needs are changing or have changed over the last 20 years or so. You also, what I'm hearing there is that different bits of the NHS, because the NHS is a number of different individual parts, isn't it, rather than one thing. Some bits of those aren't communicating necessarily well with each other. So you've got a person going to a GP, but then perhaps not quite getting what they need, and therefore going to A&E, ED, the emergency department. And the title of that publication, Nowhere Else to Turn, is kind of ED, isn't it? Because it's the place that's always open and the place that you can go to, and actually you will get cared for and see people there. But it does mean that it attracts lots of people. And some of these people, I mean, I read in the report that my colleagues Makoto and Katie did some research on. Some people are attending 300 times a year. So like basically once a day. Give me a bit more on what kinds of people and what are their needs. Why is that happening?
Well, I think there is that wide range. It isn't a massive amount of people who are attending 300 times. They are usually people, there could be a mix of people who have an absolute need to be there. And there could be a mix of people where services are closed, out of hours, weekends, and feel that there's no one else to connect with. And so there's a range of issues that people go to A&E with. And so we can't kind of just define what it is, but usually we're not working on those presenter needs that they turn up with. And so it's usually the socioeconomic needs that are lying underneath the underlying causes for why people are attending that we usually support with. And sometimes it's just making that connection where they need to be connected. And so you can signpost as many places as you want for somebody to go to. It doesn't mean they'll actually go. Right. And so having that confidence to go as well, and that knowing that that it's going to support in the long term, but sometimes they need someone to go with them and support them to do that. And there's not a lot of services that are able to do that.
So the British Red Cross High Intensity Users Officers does that. You find those few people, as you said. It's not everybody that attends in high numbers, but I imagine for every hospital there's a list of 50 or so, 100 people that perhaps are in that category. And then what do your team do then with them? They get alongside them, they go and meet them. What else do they do?
So we do get a list of people that we work with, and we're able to choose from that list. So we get a really balanced caseload. So we're able to pick some who are attending within them 300 brackets, but some working in a very preventative way as well. So to be able to meet the needs, show that impact, you've got to have that really good, strong, balanced caseload. And so we look to employ our staff with a wide range of knowledge, skills and experience. And so they look at working in a very trauma-informed, person-centred way, and they use coaching techniques to understand what matters to people. And that has got to be the thing that we look at. We often do quite a lot for people. And so we need to be working alongside people, looking at what they want to work on, looking to what they want to work towards as well. And so we look to build up a really good co-designed support plan with that person. And that involves setting some really good goals. And they're usually some smaller goals that you may be able to work towards on an immediate basis and see that and build that confidence, and some more challenging goals to work towards as well. And that kind of really empowers people to understand their own health needs, manage their own health and well-being, but it connects them to the right services. So we're not always about solving and fixing problems for people. It's coming up with them solutions and being really connected to the primary care network or the wider voluntary community sector. So we're really embedded in our communities. We have a greater understanding of what is available to be able to support people to go, have you tried this? And what was that like? And so we plan for appointments and we debrief after the appointments as well. And so it's quite wide and varied what we offer. We don't always know what we're going to work with. It's not always the presenter needs, as I said before. And so it might be something like debt, or it might be housing issues, relationship issues. A lot of people are coming with long-term illnesses and pain management, loneliness and isolation.
Right.
But there's a lot around poverty at the moment. So you're looking at the cost of living rise, which brings about food poverty and fuel poverty, and that affects quite a wide range of people. So it's very different in the fact that we work with anyone from 18 upwards, but it could be a wide range of people up until end of life, really. And so it affects a lot of issues, affect people in different ways. And so what we look at is making sure that these are the person's goals. And an example of that is we'd supported someone who on paper had a real mental health issue and was not connected to services, not attending appointments. And so we were kind of advising for that, you need to connect with this and this is what's available in your area. And he's just said, I don't want any of that. I just want to learn to sing.
Okay.
And so we took him for singing lessons, and as that progressed, because we enjoyed doing that as well, we go alongside and we get involved, and we found that there was a local mind group as well which did singing lessons. And so we were able to introduce that person to that. They could then have the mental health support that they needed in such a safe space. But I think sometimes when you're doing what you enjoy and you're connected to your community and you have that real elevated sense of well-being, that you are in a better place then to access all the things that are escalating underneath as well.
Yeah. So your team sound amazing, actually. They are really good at getting to know somebody, and not just getting to know them, but getting to know what they need and helping coach them into understanding what they need as an individual as well. They also seem to be amazingly connected to not just all the health services in their area, not just the GPs and the community services and the hospital and the right kind of medical people, not even just the right social care people, but equally all of those other groups, like you talked about their singing groups and others. They must have an amazing talent for being able to pull all these things together. Where do you find these people?
The adverts go out across the board, really, anywhere and everywhere. And obviously the interview process is really important to find that special person, that person who we feel can be sat across from somebody and sit with somebody in some of the most traumatic disclosures that you might have, some really horrendous living conditions that people may be living in, and just being able to offer that branch of hope to someone that we're not here to fix everything. We're not the oracle on everything. We don't have all the answers, but together, let's find them. Let's find these together. Yeah. And so what we want is someone who's able to offer those solutions without jumping in to fix them, because we want people to learn how to manage. We want people to feel empowered to manage when we effectively close that person, because people become dependable on services. And we need to take that power shift away for not going, I've got all the knowledge, I've got all the skills, but you've got all the answers, because the person sat across from us does have all the answers of what they need. And sometimes it's that coaching of what have you tried before, what would you like to try differently, what went well, what didn't go well, helps people then to problem solve, but also remain solution focused, to be able to plan. And I think a lot of people feel very disconnected from their plans. And so we make plans around people and we go, oh, it's not working. Why isn't that working? And that person's not involved in it. And so people have to be really involved in their treatment plan, their support plan moving forward, and have a good understanding of what that means as well for them.
Understand. So it's kind of empowering them to in the long term make the right choices for themselves, and becoming less dependent on those professionals or other people in the NHS and other people in other services making those decisions for them. So give them the power back. Now we've talked, I mean, this all sounds amazing, and really helpful for the individual, but tell me a bit more then about how effective this is in terms of supporting those people. So like the example of somebody turning up to ED 300 times a year, if they then get some support from the British Red Cross, what kind of impact does that have for them and therefore for the wider health and social care system?
I think the main priority is for the person that we support, really. And for me, that helps them reduce the amount of times they go into crisis or escalate. And so they feel that they've got that skill to manage and prevent that escalation and prevent them from having to go to A&E as the person who fixes the problem. So it helps them to manage, who do I go to next? Who's the person who needs support with that? Is that urgent? Is that something that I can wait for? Is that something I need to ask questions around? And so that improves people's capacity to have the confidence and the independence to manage. And that we get that feedback from the people that we support. They often tell us that, you've given us the confidence back. I feel more in control of what I'm doing now. And then that obviously then will lead to improved well-being. And we do assessments to evidence-base that as well. It helps them to feel better connected to their community. And I think once you feel you're part of your community, you're contributing to society, who's there for what. We used to have that years ago. People go to the local shop and have a chat. I think everything's brought on now to keep us quite isolated. And so for the older generation especially, they're really feeling that. And I think once we went into COVID and isolation, a lot of people didn't recover very well from that as well. But I think it's looking at what went well then as well, because you did stay connected and something did happen, and bringing those skills back out for people. So I think it's them having that real understanding of their own health needs and how to self-manage those. For the wider NHS, obviously our role is to reduce A&E attendances and ambulance call-outs and non-elective admissions, but that leads to a smoother flow within urgent and emergency care. And we talk about that system flow and then winter pressures and being ready for those and being able to support with them. We are always making sure that we align with national frameworks as well. And so we are aligned to the NHS long-term health plan, with also the prevention priorities within that, and with the neighbourhood plan as well, which I know all the frameworks are coming out this week as well, and they're talking about that. And to us, it's like, we already do this, we're already connected. And I think we know that works, and we've been supporting that for a while. And so for our systems, that means that we are creating better partnership work and more connectivity with people. That sharing of information is really critical to providing that fuller picture of what is happening. So a lot of people work online. We actually see people face to face, so we're able to see what's changed, what are the presenting needs are changing in somebody, but what's the environmental change as well. And sometimes that makes a big difference to someone's support, because I know virtual wards were really shocked when they saw some of the living conditions that people were in. And so it's being able to bring that back and bring that appropriate referral back for that person as well. But that brings more MDTs, more integrated care pathways, multidisciplinary teams working together for whose actions is whose. And that gives us a strong evidence base for prevention focused investment. But we look at society as a whole. And so it's about that equitable access to care, reducing the health care inequalities, making people more resilient. And so we've got empowerment rather than dependence for people.
Right. So you're supporting in the I was going to say the really long term. It's not that long term, is it? It's the 10-year plan, the NHS plan, which is to support a shift of care from hospital to community. It sounds like you're absolutely
Already
doing
doing
that
that.
with already doing that, yeah. And also a shift from reactive care to proactive and preventative care as
Yeah.
well. And you're also already doing that by setting people up and giving them the tools to manage their own health. In terms of results, so if you have a list of 100 people from one of the, you're operating across how many sites? Is it 16 or more than that now?
16, yeah.
16 sites, yeah.
Well, because kind of contracts come and go as well. We've got a few in the pipeline as well.
Okay. How, of that list of 100 from an example site, I mean, what are we talking here in terms of 100 people have been turning up regularly to ED? At the end of being supported, at the end of the process, what are those stats now? Has that come down significantly?
Well, we're meant to reduce attendances, conveyances, and non-elective admissions by 40%. That's the KPI that we have to reach.
Okay.
But we very often exceed that and really excel that.
Yeah.
In one area in particular, it was 100% across the board that we'd lowered that.
Of that list of 100 people, for example,
No,
on the list,
100% for that person. So it was preventative for that person. So we don't always get the opportunity to work with every one of those people because we've, funding means minimum staff. We'd love that to be increased for more staff so we can reach more people. So we're quite selective at being able to work with very balanced caseloads of 12 to 15 at a time. But we aim to try to give everybody the opportunity within that list, within our capacity to make a phone call to everyone to offer the support to them. And so it is a priority for us to try and reach as many people as possible. But we may not reach everybody on that list as well.
Yes. But the people you do reach, it's somewhere between 40% of your target and 100%.
And 100%,
is what you've achieved in some cases. So it's an incredibly effective way of preventing those ambulance call-outs, reducing those numbers of people turning up to ED, and admissions is a really big one because we did a little bit of research a few months ago looking at the costs in the NHS, and you've got prescription costs, GP costs, outpatient costs, costs of surgery for patients. The biggest single cost in the NHS are those non-elective, those urgent beds in hospitals. They account for the largest single area, and if therefore you can prevent people going into those, which you are in a very effective way, that is an extremely valuable offer to help make those NHS services way more efficient.
And it's one of the things that the neighbourhood plan wants to address as well, to reduce that. And I think for us, it's finding out why people are going to A&E. And there are absolutely, as we said before, the people who need to be there. So you may have heart problems, you may have really poor breathing problems that obviously the ambulance is going to convey you there. I think what we need to do is have those local teams in place, and this is what the neighbourhood plan wants to have a look at, and maybe a triage, a single point of access, but being able to look at the reasons behind why, say, you're having frequent falls. Is there a falls team involved? Is it down to your diabetes? Having that real bird's eye lens on everything, really, and not just looking at those presenting symptoms, that wider picture. What is creating this? What is causing this? What can support with this? Who can support with it? And who next can support with it? So we're not talking about like a plethora of people being involved. And that's where sometimes we case manage that as well. And so it's managing, well, who's next to come in and who's the next point of support, and not overwhelming people with who's supporting me and when's that happening and who else. It's who's the right people at the right time for that person as well. And so it might be that we know that's what was needed next, but let's get this more urgent and emergent support in place. And it may be that that's the one thing that prevents that admittance. And we worked quite a lot a while back with care homes in particular, who there was high numbers of catheter change, and it was more about the care homes not being trained at that time to be able to change the catheter themselves. So it'd be an ambulance call out, it'd be a 20-hour wait, it'd be 20 hours sitting in A&E, it'd be waiting for that bed. Then you've got bed sores, then you've got infection setting in, and it's recognising that this needs to happen sooner rather than the 6 weeks let's have these changes in 4 weeks. But there's such a pressure on different services, such as district nurses, to be able to do that. The better point is to train that person up to do that. And so when we're looking at switching hospitals to communities, we've got to make sure people have got them skills as well. So are there enough staff in place to deliver what we're saying that people need? And so you've really got to have a hyper local focus on places to make sure you know that is what that community needs, and how to invest that money and that time. And one of the things we've got is time, and I think that is something a lot of services don't have. You know, you have 6 weeks to work with someone, and you also have your criteria list of what you want to change for that person. We don't go in with what we want to change for that person. We look at the broader picture, and then once we set a goal, we move on, we review, we move on, we review. And so we're constantly reaching those goals until it comes to a natural end for that person.
Amazing. What is your plan then for the next 20 months? I mean, you said you've got 16 sites now. You said there's a few more in the pipeline, of course. It sounds like a brilliant initiative that lots of places across England and the rest of the UK should be adopting. Like, what's your vision for the next 20 months?
We would obviously like to scale up the HIU model and have that into more integrated care systems, particularly where ED pressures are at the greatest. I think it's one of the things that we feel there is a lot of frustration, because we are relieving that pressure on the NHS staff. We're relieving that system pressure as well. It is kind of ticks all the boxes. We are aware of what is needed to make that happen for that conversion into hospital communities. We can put those 3 shifts in place with you. We can support your neighbourhood plan as well. And so investing within the HIU model, it just seems to me like a bit of a no-brainer, really, because it ticks all the boxes. But I think what we need to do is look at strengthening that evidence and evaluation. So when we talked before about non-elective admissions, it's about cost avoidance. We can't possibly say that that's an actual cost because we don't have those figures, but maybe looking at that wellbeing impact, the reduction in crisis activity, and mapping that nationally as well, because we are one of the largest holders of HIU services, and so we're able to plan and map across that nationally. We're not just looking at what's happening on a local focus, we're looking at being able to what's happening across the country as well. So we want to drive that early intervention, preventative work really quickly and build those partnerships. But I think it's more about making sure that the workforce are highly trained. They're really in a trauma-informed way, because some people have some really entrenched trauma, and being able to sit with someone and allow them to open up, it's a real gift. We're really honoured to be on that journey with someone as well. But we would like HIU to be a core component of urgency and emergency care transformation plans that are coming in place. And so we can help and support bridge that gap between hospitals and communities, but get the best outcome for our people. We don't want it all system-led. We would like it to be a very bottom-up approach, that what matters to that person at the end, what is the outcomes for that person? How do we measure those outcomes? How do we measure that sustainability? And how are we looking at what services are really needed to support communities as a whole and within your local area as well?
Understand. So person-centered, a population. I mean, this is population health in its thing, isn't it? Really, in its entirety. That you're looking at those users with specific needs, zooming in, helping them on an individual basis to figure out what they can do, and stopping them, of course, in the outcome is stopping them going to ED. But the better thing is helping them in the longer term. You talked. I wanted to ask about barriers. Your vision is therefore expand. One of the barriers you touched on there was having the right staff, because it's as we've said, it's a complicated job. You need some brilliant people to be able to connect, to be able to engage with people, coaching skills, counselling skills. I guess staffing to scale up is going to be one problem. What are some of the other barriers that you might be experiencing?
We basically share quite a lot of barriers and observations with our commissioners. So it may be, again, quite local barriers that we see, but it may be that we are, because one of our recent researches that we've just done was seen and heard, and basically it identified two cohorts of people, and they were younger people with mental health issues and older people with long-term conditions. And so the barriers for those is that they haven't got access to the care that they need within the community. So being able to point out what are these trends, themes that are happening across the board, and being able to show that evidence, to be able to direct to the right services. It might also be that people are directed to services that are quite far away for them, and financially or with mobility issues, they're not able to access those.
Okay, yeah.
One of the other things that we noticed was that it can take up to 10 days for discharge notes to go back to the GP surgery. And I know there's high capacity issues for GPs, but there isn't always a follow-up appointment to assess those reasons for A&E attendance until somebody becomes a frequent attender.
Right.
And so I think it's being able to address that. And I know within the neighbourhood plan, we're looking at GPs being the hub and the centre of that as well. And we're really connected with our GPs. We work really well with the surgeries across the board, those who are linked together and those who are quite isolated and quite saturated in very poverty driven areas. And I think for us, having that connection and realising that you're not shifting it from one place to another, you're not giving someone else the problem. We're here to support and here to work together as well. And I think it is whatever barrier that comes up for people, it's being able to bring that back. And it might be a very individual barrier, but it might be a collective barrier.
Yes.
And we're able to see that with having so many teams across the board as well.
That's really good. I mean, you've got those lots of sites at the moment, those 16 sites. That does give you, as you said, a really nice opportunity to kind of evaluate and to iterate, do check, act, PDSA on all of those sites to kind of figure out how to solve some of these challenges that then make the scale up across even more sites that whole bit easier in the long run. Brilliant. Thank you. So that's what you're going to achieve over the next 20 months is more scale up, more of this. That sounds great. Diane, I wanted to ask you, I've asked a few questions here. What's the question I haven't asked yet that you want me to really ask?
I'm not really sure, to be honest. I just think, how do we scale that up? How do we support your neighbourhood plans? We know there's 43 across the country. We'd love to connect with all 43 sites and to be able to see how we sit within that. How do we support you to roll out these plans moving forward? How do we use our knowledge and our skills to be able to support you to provide better outcomes for people? And I think we're in a very good place to do that, because we don't just have HIU services, we have a number of services across the board. So I think we've got quite a good knowledge of what's needed. So
let me ask you that question then. How are you going to reach all of those 43 different sites? What's the way?
The plan is to get this podcast out, first of all.
Step one.
Share as much as possible. We need to be on those platforms really, and that's what we've done. We presented at a number of places at the moment. We've done some lunch and learns as well. We've done NHS Confed, and it's just having that opportunity to be at those places. So we are trying to reach as many people as possible, and we are very close. To be fair, a lot of our staff members within the British Red Cross are really close to commissioners, and it's having those rich conversations with commissioners to help guide them as well. And so I think we're able to do that. We're in a best position to do that. We do open that up as much as possible. And, obviously anyone can contact us if they would like to be able to engage with us at any time as well. Very good.
Well, we will do our bit via this podcast and other things to help spread the news that the service is excellent. It really helps people. It really helps the NHS become more efficient, and it really helps communities listen and work together. Brilliant. Thank you so much, Diane, for joining me today. And more importantly, the amazing efforts that you and your teams are making and doing for the lives of individuals. And of course, the kind of benefits therefore bringing the NHS and others.
And thank you for supporting us at the beginning of all of this and where we are now as well, and continuing to support us. We really appreciate it.
Very good. I mean, I feel really proud to have been involved. I mean, it was Katie and Makota, my colleagues, that did the original piece of research, and I'm really happy that it's been able to help provide impact. And the scale now, having 16 sites doing brilliant things, is really heartwarming. So very much appreciate.
Thank you very much.
Appreciate that. Very good. Thank you so much for listening to the podcast. We will be back soon with some more fantastic insights for leaders in public services. So don't forget to subscribe and follow us on LinkedIn. This has been the PSC in Conversation. Thank you.